When it comes to hepatocellular carcinoma in particular, it's a very heterogeneous, very diverse kind of patient population because you have very defined risk factors which are different from east versus west in terms of worldwide incidence. So in the US, our main risk factor is hepatitis C and also fatty liver and NASH related liver cirrhosis, while in the east countries it's mainly hepatitis B. So that's what's driven our hypothesis. There are some reports from several studies before about sub-analysis of results tapping into this, the potential differential effect of the hepatitis status on the treatment outcome, but there has never been any dedicated study looking into this. So we did that at MD Anderson, and it's the largest single center conducted study today that looked into this effect, the differential effect of the hepatitis status on clinicopathologic features of the disease and also the treatment outcome. So what we found was very interesting. So number one is patients with hepatitis B related hepatocellular carcinoma were confirmed to have more advanced clinical pathologic features at baseline. They were also, they tended to have lower magnitude of survival outcome. So although we didn't find statistically significant survival differences, it was lower survival all over across the board, for all categories, no matter what treatment they have received, whether local or systemic therapy. But again, it's single institution, it's retrospective. So that's what we allude to, that we need to have more prospective studies to prove this concept. The clinical pathologic features differences were significant. This is the main finding of our study, that patients with hepatitis B associated HCC, they have more aggressive disease at diagnosis, which has got to do with the pathogenesis of this disease. So in general, they tend to have more aggressive disease, more incidence of metastatic disease, more incidence of vascular invasion by the tumor, which we think that's why they tended to have lower magnitude of survival no matter what treatment they have received. So the implication of this is really critical. So we have been discussing about how we should be conducting studies based on the risk factor. So this is another evidence to prove this concept, that we should really be focusing on risk factor specific trials. So instead of enrolling patients for local or systemic therapies from different countries with different risk factors, we should really be focused on a more homogeneous approach to focus on single demographics, geographic location, and even risk factor in terms of hepatitis B versus hepatitis C. So that's one of the major implications of our study. And I think once we have more prospective studies from different institutions to prove the same concept, we're going to start seeing this risk stratification and randomization based on the hepatitis status, and hopefully we can see dedicated studies just designed for specific risk factor. In this case would be hepatitis B versus hepatitis C related hepatocellular carcinoma. In the era of personalized therapy, in terms of hepatocellular carcinoma, we really have a low-hanging fruit, which is basically the clinical subclassification. So while we still have to dig deeper and look into molecular substratification, I think for HCC in particular, we have to start with the clinical subclassification and look at the disease different. So we should divide it into hepatitis B versus hepatitis C versus NASH-related hepatocellular carcinoma. And then for each category, we still do what we usually do for any other solid tumor, to do molecular subclassification. But upfront, we believe that we should really work on decreasing this heterogeneity by focusing on risk factor specifics.